Hello and welcome to today's webinar, the third and final in our TTAC webinar series, Beginning at the Beginning, Early Childhood Mental Health Consultation in Infant and Toddler Care. My name is Meg Beyer, and I am the Assistant Director of Strategic Operations at the McSilver Institute for Poverty Policy and Research, and I'm one of the partners for the TTAC project, and I'm really thrilled to be joined by my colleagues, who we'll introduce shortly, as well as all of you who are tuning in today for our third and final part of this webinar series. I'm going to run through a few logistics about today's webinar before our presenters begin. So as we've done in the past, this webinar is being recorded and it will be posted along with the slides to the TTAC website, so you'll be able to re-listen, review, and share with your colleagues if you're interested. We will be taking questions throughout the entire webinar, and we ask that you chat in your questions using the chat box functionality, selecting the All Panelists on the drop-down. So if you look to the right-hand side of your screen, you should see the chat box functionality. And if you click the little arrow that's pointed down, we're asking that you select All Panelists so that all of our presenters today can see the questions as you chat them in. My wonderful colleague, Kevin, who is serving as our WebEx host today, is going to collect all of the questions that come in into one document so that we can kind of review them. We've set aside time at the end of today's webinar to address these questions, but know that everyone who's been participating has been chatting in really thoughtful, wonderful questions, and we don't necessarily think we'll have time to address all of them, but just know that we do collect all of the questions. So please don't hesitate to chat those in throughout the webinar. For those LMSWs and LMHCs interested in obtaining CEUs, you must have attended all 3 webinars in this series to obtain the CEUs. Following today's webinar, you will receive information via email about how to obtain these CEUs through NYU's Silver School of Social Work. So by attending all 3 webinars, you're at a good place to receive CEUs. There are additional steps that you need to take as well, and you will receive an email kind of walking you through those steps. So that will come after today's webinar. And again, you must have attended all 3 webinars in order to obtain the credit. Finally, at the end of the webinar, we are going to send out, as we've been doing in the past, a feedback survey using the chat box functionality. Kevin will chat this out right before we start answering questions. We ask that you click the link that is shared in the chat box and complete the feedback survey. We appreciate you filling this out and taking the time to do so. It really does allow us to understand your experience in participating in the webinar and also how we can enhance our future TTAC offerings. So we thank you in advance for completing this. And with that, I would like to thank you all for joining us, and we'll hand it over to Evelyn Blank, who will kick us off for this morning.
Thank you so much, Meg. My name is Evelyn Blank, and I'm the director of the New York City Early Childhood Mental Health Training and Technical Assistance Center, otherwise known as TTAC. TTAC is funded through Thrive New York City in collaboration with the New York City Department of Health and Mental Hygiene. TTAC is a partnership between the New York Center for Child Development, my agency, and the McSilver Institute on Poverty, Policy, and Research. And just as a means of background, New York Center for Child Development has been a major provider of early childhood mental health services in New York, with expertise in informing policy, but also supporting the field of early childhood mental health through both training and direct practice. NYU McSilver Institute for Poverty, Policy, and Research, which houses the Community and the Managed Care Technical Assistance Center, otherwise known as CTAC and MTAC, offer clinic, business, and system transformation support statewide to all behavioral health care providers. TTAC is tasked with building the capacity and competencies of mental health and early childhood professionals through both ongoing training as well as ongoing technical assistance. And I just want to direct people to our website. I know that each time people ask questions about whether or not the slides will be posted, they will be posted on our website. If you go to past events, it'll be posted within 3 to 4 business days. And you will not only be able to receive the PowerPoint there, but also to get a recording of today's webinar. So we'd encourage everybody to go to our website and to really look for upcoming events, to look for other resources, as well as to look for archived past events that we've done. So it is now my privilege to introduce Kadija Johnston, who's really been a pioneer and a real thought leader, not only in the area of early childhood mental health consultation, but also in working with infants and toddlers, which is an area that I think is getting increasing focus. And I know there's some exciting initiatives in New York State right now to focus on consultation in infant toddler settings. Kadija Johnston is a clinical social worker who's been a practitioner in the field of infant and early childhood mental health since 1985. For the past 15 years, she has been the director of the Infant Paired Program at the University of California, San Francisco. She developed an approach to early childhood mental health consultation that serves as a model for other organizations, locally, nationally, and internationally, and she's been a true pioneer and leader in the field of early childhood mental health consultation. She's provided technical assistance and training in early childhood mental health consultation in 23 states as well as internationally. She served as an expert advisor for and continues to be involved with the SAMHSA-supported Center of Excellence in Early Childhood Mental Health Consultation. And she's also a founding member of RAIN, a group of national experts advancing policy, practice, and research in early childhood mental health consultation. She writes and lectures nationally. In addition to numerous articles, she co-authored a seminal text on the subject, Mental Health Consultation in Childcare, Transforming Relationships with Directors, Staff, and Families. So it is now my pleasure to turn it over to Kadija. I'm very sorry to see this being our third in the series of 3 webinars. They've been incredibly informative, and we look forward to another interesting and stimulating presentation. Thank you, Kadija.
Thank you, Evelyn and Meg. Yes, as we acknowledged to one another before everyone joined us, I too am a bit sad about this being the end of our 3 sessions, although I feel so grateful to have had this time to talk about the foundational principles and practices of infant and early childhood mental health consultation, which I will turn to momentarily. But unfortunately, this being the end of our series is not the only thing that is weighing heavy on my heart and mind today. Undoubtedly, like many of you, I'm saddened, enraged, and disturbed by where we as a country find ourselves today, still mired in the racial injustices that we were born with and have battled for nearly 250 years. I wanted to express the swirl of feelings that I'm sitting with today, but more importantly, it felt essential to me to use this platform and my privilege to give voice, to lend my voice to the chorus of voices in my state, I'm sure in yours, and everywhere in between, that are once again righteously demanding justice, imploring for equity, and reminding us we have to do better. We in the field of early childhood, in our work with and on behalf of babies, I think we have so much potential and with that responsibility to combat racism and other forms of oppression. From getting a foothold right from the start, I hope that we can all commit to using our collective influence to ensure that Black and brown children see the starts that they deserve. And that's what I'm going to be talking about specifically today, those beginnings, the starts that babies get off to. In the first 2 sessions of this webinar series, I described the theoretical premises and essential elements of early childhood mental health consultation. In this, the third and final segment, we're going to apply these foundational principles and positioning specifically to consultation around infants and toddlers. First, focusing on the unique characteristics of and some of the concerns that arise when caring for babies. I'm going to describe ways that early childhood mental health consultation attends to and adapts to the particularities of providing care for children under 3. Like the past 2 sessions, though, I will highlight and hypothesize about the impact that current global health crisis is having and will likely continue to exert on how care is provided for our youngest children and how this will likely require revisioning of some parts of the practice of consultation and likely amplify others. To talk about the particularities of the practice of consultation around infant and toddler care, I think we have to begin by appreciating the specialness of this period of life. So I'm actually going to spend a significant portion of our time today talking about babies. My choice of this emphasis is partly due to the fact that I find there to be little that is as fascinating as thinking about and talking about infants. Additionally, as mental health consultants, understanding early development is essential, I believe, to our being of use to those with whom we consult. And we might think, child care providers know a lot about development, and they do. If not from academic study, from experience having cared for many children of a certain age. So it might be hard for us as mental health professionals who often get much less academic training in typical development to think that we have much to offer. What I am suggesting, and as I've spoken about in previous parts of this series, is our hopefully deep knowledge of infant mental health principles can, and I believe should, undergird and inform our approach to consultation. This is what we have to offer. Derived from infant research and based on relational and attachment theories, infant mental health has advanced the notion of development as a transactional phenomena. So what does that mean? What it means is that development is dynamic, that all domains of development are influenced and in large measure determined by the quality of the interactions that are offered to an infant. Although we have sensed it, I think, intuitively, if we've been privy or privileged to having spent time with the newborn, infant research has really reified for us that babies arrive ready to engage. Newborns come pre-programmed, hardwired to make relationships with whoever it is that is caring for them. First capacity that they come into the world with is that they actively seek stimulation. And the stimulus that they most prefer is all that is associated with humans. How we look, how we smell, how we sound, what we feel like, that's what will attract and hold their attention longer than anything else, any other object. At 2 weeks of age, they scan faces differently than they scan inanimate patterns, and they stay fixed. Even if you put up a rudimentary rendering of the human face side by side with a drawing that contains the same elements, two circles, a triangle, and a rectangle, but they're just slightly askew or reconfigured in one as opposed to the other. 2-week-old infants will stare 10 times longer at the picture that resembles a face. And neonates quickly come to distinguish between one caregiver and another. By 3 months of age, an infant will respond with a specific set of physical movements to the voices of different caregivers. The infant is actually telling us through these different movements that they know that mom's hearty hello is usually followed by belly blowing and an exhilarating toss in the air. And the baby anticipates this and prepares himself for the tickle and toss. Whereas the voice of his child care provider, who usually swaddles and pats, encourages a distinct set of body movements in the infant, suggesting he's readying himself for the wrap and tap. His movements suggest that he is not only differentiating between caregivers, but also tells us that at 3 months of age, he is developing relational expectancies and that he acts based on those expectations. Babies begin to develop preferences for the familiar and predictable. What they get is what they take, and they take it very seriously. If what they receive is respectful, contingent caregiving, then of course they're off to a really swimming start. But we have to remember, despite all the extraordinary relational capacities that babies come into the world with, they don't come in with what I call a quality caregiving compass. What I mean is they don't know the difference between what we would consider as good and poor caregiving. Whether exquisitely attuned care, benign neglect, or harsh mishandling, babies believe that is what relationships are like, what the world has to offer, and exactly what they warrant. In relationships, both the adult and the infant, as I'm suggesting, are active contributors. However, the infant, of course, is more greatly influenced by the quality of the relationship. Why? Because he has no experience with which to compare it. He's just learning about the world, what it's like, what can be expected, what can be controlled, how safe or dangerous it is. And an infant only learns these things through his interactions with caregivers. This accumulating experience acts as a continuous organizing filter for what he can expect of all subsequent experiences. And for the pre-verbal infant, these qualities of the interaction are both the medium and the message. What I mean is that the infant is dependent not only on what is conveyed, but how it is conveyed. When a caregiver is diapering or feeding a baby, she's not just satisfying needs for comfort and food, but at the same time, she is meeting another primary need, the need for human connectedness. How she connects, the contingency of her responses to the infant is crucial. The dialogue that develops between an infant and her caregivers is the basis for later verbal communication. And it's also the basis for other really important aspects of human interaction. Things like turn-taking, sharing, and empathy are often expected of preschool-age children, particularly in childcare. Repeated attempts are made to teach these ways of responding. And I'm not suggesting that these skills shouldn't or can't be taught through instruction, but what I am saying is that the foundation for these capacities are being established from the first moment of an infant's life. A preschool child's ability, or conversely their inability to share or empathize or talk or take turns, is in large measure determined by a lifetime of relational experiences that convince her of the possibility and benefits of these ways of behaving, or unfortunately, quite the opposite. The 2-year-old with little language may be convinced of the futility of verbal expression because his cries went unheard and his babbling did not successfully signal a response that met the need it was expressing. Or the 4-year-old who yells out in circle, unable to wait her turn, may have been the little one who had little back and forth that characterizes attuned caregiving. Therefore, her relational experiences leave her assuming that there is no mutuality to exchanges, that people don't freely give you turns. You have to forcefully take what you need. She can't trust that a caregiver, that an adult will really respond to her wish for a turn. What I am suggesting is that involved in the everyday exchanges, the moment-to-moment interactions between infants and their adult caregivers, there is communication, there is turn-taking and sharing, there is adaptation to and regulation of one another. And the infants are continuously interpreting the behavior of the caregiver, not only as a message about what the world has to offer, but as a message about who they, the child, is. If we find the child's messages important, she feels valued. If we are burdened by her, she feels burdensome. If we are charmed by her, she might just believe she's charming. And if we find the baby worth our attention, she sees herself as deserving. The child's sense of herself as lovable or enraging, incompetent or incredible is embedded in the transaction between herself and her caregivers. Really important impact and input from the beginning. And every domain, as I'm suggesting, is impacted. Language, cognitive, but especially social and emotional development is influenced by relationships. The infant's mental health is supported or conversely eroded by the relational messages she internalizes. I've given you here the 0 to 3 definition, and 0 to 3 defines infant and early childhood mental health as the developing capacity of the child from birth to 5 years of age to form close and secure adult and peer relationships, experience, manage, and express a full range of emotions, explore the environment and learn, all in the context of family, community, and culture. This definition of infant mental health speaks to the relational contributors. I have also created my own complementary definition, which you also see on the slide. I describe mental health, which I see as synonymous with social and emotional development, as the thoughts, feelings, attitudes, and expectations that are evolving about oneself and the thoughts, feelings, attitudes, and expectations that are developing about others. One's sense of self and one's worldview are flip sides of the same coin. And for young children, that coin is their primary relationship. Early relationships play a crucial role in determining each child's expectations of himself, others, and the world. If a child's needs, be they basic and ordinary or exceptional and extraordinary, have been mostly understood and responded to, he'll begin to internalize a mostly positive sense of self, and he'll expect that adults are probable partners in pleasurable discovery, people he can trust to accurately read and respond to his cues, protect him, and offer help when he needs upon it. While this is exactly what we would all hope, we have to also be aware that an opposite experience in relationships will create opposite expectations and impact a child's mental health. Contributions, of course, to negative expectations are complex and multiply determined. Because they are active contributors to the quality of the relationship, we need to remember that an infant's constitutional compromises or sensory sensitivities may make deciphering his cues and meeting his needs very difficult. A caregiver's ability to accurately decode and adapt may, despite their deepest wish to do so, be disrupted by distortions based on their own, on the adults, parents, or providers' past trauma. A lifetime of relentlessly harsh realities or daily stressors, or maybe even preoccupation caused by a pandemic, may muddy a caregiver's ability to accurately read and respond to the messages their baby is sending. Each, to relatively different degrees, influences the relationship with the child. But over time, all affect the child's sense of self and other, their mental health. Whether 3 months or 3 years of age, obviously, again, to relatively different degrees, babies bring their expectations, their attitudes, and their feelings about self and other into childcare. The child care provider confirms, refutes, and adds to these relational expectations, a really powerful role. The child's course of development and their sense of self adapts to the quality of the interactions offered in childcare. So it means we have to think about those interactions in childcare as they contribute to children's mental health. As the number of young children spending significant portions of their lives in childcare grows, the relationships offered in these settings are increasingly crucial in terms of children's mental health. The majority of infants and toddlers in this country spend some time or all of their day being cared for by someone other than their parents. By the age of 1, almost half are in child care for more than 30 hours a week. Child care isn't a moment bracketed off between real life. It is real life. Once we think about the importance of very young children's experience in relationships as central contributors to their development, as I've been talking about so far, and recognize that most wee ones in this country whose relationships we're counting on to be better are spending their time in child care, we can't help but be primarily interested in the quality of those relationships that exist in infant and toddler care. I believe that it's only by acknowledging relationship as the central issue in early care and education that we can come to truly appreciate the contribution that child care experiences make to infant and toddlers' overall development and specifically their mental health. It's only, I think, when we recognize relationships as the major issue defining quality of care that we'll begin to assess and value quality of care in terms of the adult-child relationship. And I believe that research, all of the research over the last decade that has looked at quality care indicators in early care and education confirms this. What is clearly articulated and replicated in the research are those variables that consistently correlate to quality care. In the National Institute of Human Health and Human Development study, which has been a longitudinal study over almost a decade, found that among adult work variables, the most important predictor of the quality of care is staff wages. And I have to stop for a moment to say that up to this point, we've been unwilling as a society to pay what it costs to train, maintain, and support caregivers in doing an exceedingly demanding job. Child care providers earn about half as much as comparably educated women in the workforce, and maybe less surprising, but no less appalling, about a third of comparably educated men. And actually, the more education a provider has, the more disparate their earnings. If that isn't depressing enough, provider pay hasn't kept pace with inflation. It's actually declined despite valiant advocacy efforts over the past decade. And I believe that conditions brought about by the pandemic, what I mean by that is closures and job loss, the mounting costs to take extra precautions in child care, while probably the need to care for fewer children, will further threaten the viability of the profession. Even before the pandemic, financial insecurity was a major concern for providers. That data suggests falls really disproportionately on women of color, who comprise 40% of the child care workforce in this country, and disproportionately on those working with infants and toddlers. In addition to staff wages, 4 other variables, as you see here, are agreed upon by researchers and practitioners alike as the highest determinants of quality. And those 4 variables are adult-child ratio, group size, caregiver continuity, and caregiver education and training. When ratio and group size are increased to cover costs and make ends meet, the quality of care deteriorates. These circumstances, compiled with low wages, cause higher caregiver turnover. The current turnover rate in this country is close to 50% a year. Think about that in terms of relationships. The underlying significance of these factors, though, what I'm suggesting is that if we look at these factors together, their combined effect is the effect they have on the relationship. If there are smaller groups of infants and toddlers and more adults for fewer children, and the caregiver stays with that same group of children over time, it actually increases the probability that a relationship can develop. I believe that it's education, ongoing training, and mental health consultation that then can affect the quality of that interaction. What we have to recognize, looking at these indicators of quality, what we have to recognize is that currently, most child care providers in this country don't possess these correlates to quality. The cost, quality, and child care outcome study found that the care in 600 centers they looked at was overwhelmingly assessed as poor to mediocre. And actually, infants and toddlers are most impacted. 75% of toddlers in center care and 93% in home-based care are in low or mediocre quality care settings. Babies of low-income families, many of whom are children of color, are the most likely to be in the lower quality settings. Now, I want to say that quality, both in these studies and overall, varies greatly. But that this study that I've referenced concluded by stating, and I quote, that most child care is, quote, sufficiently poor enough to interfere with children's emotional and intellectual development. So we can infer that provider-child relationships are suffering. To the degree that these relationships are inadequate, all children in child care are negatively affected. Low income and children of color are suffering most. Well, there had really been reasons to be optimistic about the direction that quality indicators were going. I'm also worried that the projected funding cuts, combined with increased costs related to the current health crisis, portend poorly for quality improvement right now. And you know, the statistics I just cited might not convince you, but really over the past 20 years, great strides have been made to focus on and improve the quality of child care. Prior to that, and since the inception in this country, child care hasn't been a service for children. It's been a service primarily for parents, freeing them for work and other necessary activities. And I'm concerned that the current circumstances will cause us to regress, to see child care not in terms of the quality provided to children, but to make sure that the economy gets going again. The need for the children of essential employees to be cared for, and now the increasing economic pressure and need for families to get back to work, is propelling the reopening of child care programs. As they do, the emphasis on physical safety, although of course necessary, is leading to the adoption of protocols that prohibit contact and obscure relational connections. As adults, we don't like it, but we can afford to social distance. Babies can't. Smiles and other nonverbal cues that babies rely on are impossible to see through masks. Prohibiting parents from entering the premises makes separation stilted, abrupt, or potentially traumatic. The comfort that could come from a transitional object or embrace of a beloved provider will be foreclosed. All these practices impede providers' ability to meet children's social emotional needs and put them, the provider and the parent, in an untenable bind to choose between their safety and providing quality care. And also, I just read a great article in The Nation on April 20th by someone named Bryce Covert called The Heartbreaking Choices Faced by Child Care Providers on the Front Line, that expresses these sentiments beautifully. I think that these anticipated changes, coupled with conditions that already existed in childcare, force us to acknowledge that childcare is really straining under the pressures that compromise the relationships offered to young children, and therefore all children's mental health is in jeopardy. Early childhood mental health consultation, I don't want to suggest, can combat all of the problems plaguing childcare, nor should it be seen as a panacea. It's especially not in lieu of paying providers what they deserve or protecting their health. However, what I am suggesting is the scope and aims of mental health consultation should be informed by and responsive to the state of childcare. The purview and purpose of the relationally focused, dynamically and equity-informed approach that I've been speaking with you about for the past few weeks was developed and has continued and will continue to be adapted and refined to respond to the changing conditions in childcare, to the childcare landscape. Viewing the quality of care as a mental health issue, the indirect intervention of consultation is aimed at supporting and, when need be, enhancing the relationship throughout a childcare community. Priority is given to the central provider-child relationship. The surrounding adult relationship, interstaff, director and staff, and parent staff are also addressed by this approach to consultation. The tenor of these connections, of the adult connections, permeates the culture of a program. Early childhood mental health consultation is about building adult capacity to foster the healthy development, especially the mental health, of all children in a child care community. To adequately address the circumstances in which infants and toddlers are cared for, though, we have to talk about the settings in which it occurs. And perhaps you are all aware, but the majority of children under 3 in this country are cared for in family child care, or, as abbreviated on this slide, in family, friend, and neighbor care. I believe these venues will be even more crucial to care in the near future, because if we think about it, structurally these settings have the characteristics that are being seen as safer and being mandated. If they can financially survive, family, friend, and neighbor and family child care inherently offer smaller spaces, less to sanitize. There are fewer and the same children typically, and a single consistent adult mostly. If historical precedent holds and my prediction is accurate, this is an optimal time to offer early childhood mental health consultation to these settings. While exactly the place we want to be, in my experience, consultation practices have to be very precisely tailored to these settings to successfully gain access and be effective. So I'd like to take a few minutes to talk about some of the adaptations that I have learned about that need to be in effect to adequately consult in family child care programs. I'll briefly describe some of the learnings from my program's experience serving family child care. First, and perhaps most important, the intimate and insular nature of the settings shapes the consultative effort. Gaining entry can be far more arduous than in center care. For many reasons, family child care providers might be more reticent to ask for assistance or allow access. The threshold we are crossing is physically and psychologically a really personal one. we're entering someone's home. Hopefully we enter every setting we consult to with the respectful stance of an invited guest. Doing so in family child care is doubly important. Emotional differences in terms of family child care also exist. It is different, and I would propose more difficult, to ask for help when you are the sole provider in a program. In a center with several staff, responsibility for a programmatic dilemma or a distressed child can be dispersed among many. Consolidated in a single provider, a sense of responsibility may manifest as a worry about being judged, blamed, or exposed. In addition to having heightened sensitivity to dispelling these apprehensions, a mental health consultant can offer material conditions to counteract, at least initially, some of these concerns. Initially interacting from a distance or somewhere other than the family home has, we have found, given the provider the proper control about how much she shares, how exposed she feels. Reciprocally, starting with a remote connection allows a family day care provider to get a sense of how we comport ourselves, how we act, how we respond to her before inviting us into her home. Kind of ironically, restrictions due to COVID-19 may impose these remote distances. I think the prohibition may be of benefit in this instance. The flip side, though, of this situation is that family child care providers often suffer from the effects of isolation, from being too alone. These feelings are likely compounded right now. To counteract the sense of separation and yet still afford providers a way of getting to know us at a psychologically safe remove, one option is to offer services to a small group of family child care providers. This format affords access not only to the mental health consultant, but offers the opportunity for the home provider to develop a cohort of peers. This was actually one of the positive outcomes of the strategy implemented in my Bay Area program a few decades ago. We started several small groups of family child care providers. One of the groups, a group of self-selected Latinx providers, actually almost 20 years later continues to connect with one another. The group independently organized their own 501c3, where through they could collaboratively hire substitutes. They host annual retreats and act as a mentoring group for new providers in their community. This is an extraordinary outcome, but I wanted to mention it because it shows the possibilities of ways of counteracting the isolation of family child care providers while providing mental health consultation. But to go beyond the venue of family child care, regardless of venue, caring for and consulting to providers of infant and toddlers presents unique challenges and afford particular great possibilities. I'm going to just touch on or describe three of these variables. I've labeled them, one, that care is body-based, two, that protective urges influence the relationship, and that three, the reticence about and opportunities for early identification and intervention are greater in infant and toddler care. And before I describe them, I want to thank two of my colleagues, Andrea Scott and Abby Waldstein, who consult primarily in infant toddler care here in the Bay Area. Before this presentation, they spent time with me and shared their expertise and extensive knowledge represented in what I'm about to talk about. So let's talk about care being body-based. When we talk about babies, we have to talk about bodies. Babies experience the world and respond to it almost solely somatically. An internal stimulus like too big a burp can completely dysregulate a newborn whose nervous system is just beginning to get coordinated. A slightly older infant learns about the properties of an object by mouthing or manually manipulating it. Excitement, fear, and hunger are all full body experiences, complete with whirling limbs and arching torsos, along with belly laughs and spit bubble smiles and scarlet-faced screams. What I'm suggesting is that reciprocally caring for infants requires providers to quite literally have some skin in the game. Sucking on a finger may be the only way to soothe. Taking a bottle is typically a tandem event. And nestling one of your primary charges in the crook of your neck while swaying heartbeat to heartbeat may be the only thing counted on to calm. Why is this level of physical intimacy important? I think because it both calls for and calls up a range of intense emotions in providers, as it does in all of us. The caregiver has to learn the idiosyncratic rhythms and meaning of movement of each child in her charge. Accurate interpretation relies on attentive and accumulated observation of that baby. You only learn over time and with intention that swaddling soothes one baby and is confoundingly constricting to another. The time and singular attention that allows such attuned care is often in short supply in group care. With permission and in the context of a trusting relationship, the mental health consultant can act as a provider's eyes. Through observation, the consultant may begin to notice cues about an infant's likes, or conversely identify the kinds of stimulation that this child finds noxious. With the provider's agreement, the consultant contributes hypotheses derived from direct observation and her experience to the co-creation of meaning, of understanding what the child needs, eventually assisting the provider in developing and delivering more responsive care. But bodies are both objective and subjective. Babies and their bodies are blank enough slates for a myriad of projections, and we all do it. And when the projections are benign or even skewed to the optimistic, what they contribute to an infant's sense of self and the world is wonderful. I mean, think about it. We put a rattle in the hand of a 2-month-old, and then we often applaud and confer brilliance on a baby who likely inadvertently jostled around enough to cause the instrument to make noise. Projections of premature confidence and great intelligence can't really hurt. Unfortunately, predictions in the pessimistic direction can. A provider who has experienced interpersonal violence responds to an infant's clenched fists as a threat, pushing the baby away from her face with a bit more force than she intended. As I spoke about extensively last week, mental health consultation can, and in instances like this, would need to address the distortion that led to the provider's behavior in order to free her and the child from the detrimental effects coming from those projections. Now, that situation that I just cited is fueled by a provider's experience of bodily trauma in interpersonal violence. And I want to say the extremity of her response that I just illustrated is a rare one. but the dependency needs and physical intimacy demanded of those who work with infants and toddlers commonly evokes strong emotions. Sensitive to the strength and range of feeling elicited, a mental health consultant validates and investigates the provider's tolerance for and ways of interpreting and metabolizing the emotions that invariably arise, especially in the care of infants and toddlers. The most common and intense feelings elicited by infants are those related to what I think of as powerful protective urges. The impact of these biologically driven impulses influence providers and new parents, as well as each one's relationship with the child and with each other. And as mental health consultants, we're not immune to the pull to protect. While biologically based, desires to defend the most vulnerable are at times also attempts to deny or compensate for an adult's disavowed dependency needs, to fend off feelings of one's own vulnerability. As in all areas of our work, we start by examining, as mental health consultants, our own responses. I'm curious about and want to reflect on what compelled me to go over and pick up a crying baby without considering how my actions would be viewed by a provider who's already apprehensive about partnering with me because she fears I am critical of her caregiving capacities. Curiosity about motivation, my own and others as a mental health consultant, generally speaking, and specifically related to vulnerability, dependency, and protection, is extended to and emphasized in our exchanges with providers and parents of infants and toddlers. We wonder first to ourselves and eventually aloud about what's contributing to a provider's seeming inability to hear the wails of an infant who, like her, hails from Central America. Confounded even further by our bias that she should have more empathy for the child. We learn that she had to leave behind an infant who was about this child's age in order to make a harrowing journey to this country. While tending to all the children is a painful reminder of what she was unable to offer to her own. Acknowledging the needs of a baby so similar is excruciating. Issues of protection and dependency are amplified even further for the parents of infants. The innate instinct to shield one's offspring from harm is expressed in a lot of ways when one has chosen or circumstances necessitate sharing the care of your precious little one with a caregiver, especially a caregiver who at least initially is a stranger. I think we often boil down the complex mix of parental emotion and label it as guilt at separation. Of course, remorse for choosing or having to place your child in child care can be common. But from my perspective, that's a myopic description of the affective range of experience of parents. There's often a sense of grief at missing moments, both mundane and seminal in your child's experience. Who wants to have been the one to miss first words or initial steps? Alternatively, parents may have moments or even long periods of actual relief, partly from the reprieve of the relentlessness of infants' custodial needs, but also relief that someone who the parent perceives as better prepared, more knowledgeable, is caring for your child. Even if it's an inaccurate projection, comfort in the professional provider's confidence is a refuge, especially for first-time or young parents. These strong emotions of parents, in concert with the provider's own feelings and past experiences related to protection, dependency, and vulnerability, imbues the parent-provider relationship with great import and often a lot of complexity. So I want to talk about the parent-provider relationship. Consultation with parents is often increased, I have found, in care for infants and toddlers. For the reasons related to a sense of competency that I mentioned earlier, along with the rapid pace of change that occurs in early development, parents of infants often welcome the opportunity to meet with a mental health consultant. I have found this to be especially true when the consultant herself is very well versed in early development, is trusted by the child care providers who confer or pass along this sense of competence and confidence to the parents. And when the stigma usually associated with meeting with a mental health professional has been addressed and diminished at a programmatic level. Comfort increases when the early childhood mental health consultant has a long-standing relationship with the program, is viewed as a team member, and is introduced and has regular opportunities to interact with parents. For instance, a letter sent out by the program at the start of the year can include a reference to mental health services and let parents know that the consultant is available to them, if in fact we are. Alternatively, the consultant might offer to participate in an open house or set aside a morning to introduce herself to parents at drop-off time. Of course, any of these options are mutually developed and decided on with the providers. Obviously, consultation with parents gets off to a smoother start when they have requested to meet. However, being introduced to and familiar with the whole parent body, I have found also facilitates parental engagement when the request for the mental health consultant's involvement comes from the provider or program. Knowing that the consultant is there for all families and hearing from the provider that she wants the consultant's involvement to assist in ensuring that the parent's child is receiving optimal care can go far to assuage anxieties that might otherwise obstruct a parent's willingness to engage. So I'm not suggesting that parents are always or even most often eager when asked by their child's teacher or program director to meet with a mental health consultant. The request is usually related to a worry about the child and therefore invokes reluctance. There's usually reticence on the part of both, I have found, not just parents but providers, because it's hard to contemplate a concern when the child is an infant. Age amplifies apprehension for many reasons. Reluctance to engage with the mental health consultant may arise out of differing levels of concern between providers and parents. Overall, though, there is a disinclination, I have found, to identify disturbance or delay in very young children. Why is this? Partly and understandably, I think it's due to the quick recalibrations that it can occur early in life. And everyone is and should be mindful not to precipitously proclaim or diagnose a malady in an infant or toddler. But as mental health professionals with a specialization in early childhood, we're not only knowledgeable about assessing, but we have experience backed by evidence that disorders discovered and treated early have better outcomes. This confidence combined with our expertise contributes, I think, or should contribute, to our willingness to assess and identify trauma-related, developmental, and mental health difficulties in infants and toddlers. In my experience, providers who've had extensive experience caring for the population of young children also sense when something is askew. When bolstered by the consultant's belief that early identification is possible and beneficial, providers can become emboldened to speak with parents about their notions, how parents are approached, their inclusion in the exploratory process, and respect for the primacy of their opinion and wishes is what matters most. The consultant can be instrumental in helping the provider establish and maintain an atmosphere of mutuality and respect in looking at, assessing for concerns in infancy. Employing some of the characteristics that we talked about last week, employing elements of the consultative stance. The consultant can support the provider-parent dialogue on behalf of the child. Primary is the ability to hold multiple perspectives. The consultant's ability to understand each participant's viewpoint without aligning with one or the other is essential, and exponentially, I think, more difficult when the views held by a parent or a provider are galvanized by those protective urges I spoke about a minute ago. A provider can be quick to label a parent as uncaring or in denial when they don't, at least seemingly and immediately, share the same level of concern. In an instance like this, the consultant helps the provider broaden perspective to include more benign interpretations of the parent's actions or inaction. As example, reminding the provider that she's seen hundreds of children of a certain age, whereas the parent has an N of maybe one or two, is one way to assuage and encourage perspective taking and encourage empathy on the part of a provider. Usually, a lack of developmental knowledge, though, is not the only reason for the difference between providers' and parents' views of a child or differing level of concern, nor is it always tilted in the direction of the provider holding the worry and the parent being the one eschewing it. But when this is the dynamic, when the provider is worried and the parent seemingly is not, the parent's outward oblivion or opposition, I think, usually belies fear. Thinking that something is wrong with your baby, or maybe even worse, that you caused it, is intolerable for most parents. The consultant might posit this possibility to the provider as a way of encouraging empathy and supporting the provider's relationship with the parent. Here, the consultant then is employing another element of the stance that I talked about last week, hearing and representing all voices. In this instance, the consultant would be representing the hypothesized perspective of the parent. Using our mental health understanding of defenses, a consultant might say something like to a provider, you know, I so appreciate the responsibility you feel to convince those fathers that we just met with that getting an assessment for autism is crucial. I know you have lots of experience where early identification and intervention made the world of difference, and you want that for them and their little guy. I could sense when they countered every observation you offered, it was really frustrating to you. You know, I couldn't help but wonder what was under that combative exterior. Right there, the consultant is posing a question, asking for reflection, but then possibly positing the parent's perspective, saying something like, can you imagine how frightening it might be to think that your only child, who we know they waited for so long to adopt, might have a serious lifelong condition? And unlike you and I, those dads haven't had the benefit of knowing there are services and support that can be helpful if, in fact, our suspicions are confirmed. That's just one example. In addition to describing a defense, the consultant's response in the example I just gave points to other factors fueling different perspectives. Differences are often due to expectations and investment associated to the role, the parenting role and the provider role, that are different. Setting is another factor. How a child behaves, what occurs or is possible to provide a home is different from what's possible in group care. Consultants presume and give voice to these differences without assigning merit or blame, seeing one perspective as right or wrong. Our job as mental health consultants is not to figure out where truth resides or broker a particular outcome, but to enhance communication and collaboration among the important adults in a child's life, fortifying the relational bridge between them so that the child can cross without reserve, being recognized and supported by all. Accepting the limits of our authority can be difficult, especially if a child we think is languishing as a result of a provider or a parent's reticence to see a disorder or difficulty. When the pace of change is slow or the outcome unsatisfying, we can hopefully remind ourselves, as my colleague Abby Waldstein told me she says to herself, that we have, quote, primed the pump without poisoning the well. Through patience with the pace of change and holding hope that experiences and action on behalf of babies will take root and make a difference in the moment or down the road, we trust in the process and the possibility. Two other parts of the consultative stance. And in closing, our patience in the form of endurance and our ability to hold hope in the form of optimistic courage is, I think, needed now more than ever. In terms of consultation to child care in this unprecedented time of a pandemic, this may mean reminding providers and parents that there is no right or wrong to the irreconcilable choices they are having to make. Putting a crying baby on your lap when the policy says not to, or leaving her in her crib longer than normal because you know her mother works in a meat packing and packed plant. Pulling down your mask momentarily to show a smile that will calm a toddler's terror, or allowing a parent to cross the threshold of the classroom for a moment for one last snuggle. These are not ours to condemn or condone, but they are opportunities to demonstrate how uncertainty can be held with equanimity and to cultivate compassionate responses on behalf of and among the adults in young children's lives, so that in a parallel fashion, they weather these times as best as possible and are able to offer the utmost compassion and care to children in their charge. So in closing, may you all take care, take mindful action, and hold hope for our collective redemption at these difficult and disturbing and unprecedented times. Thank you very much for your participation today and throughout the last 3 weeks. And now we'll return to Evelyn and perhaps some questions that we can ponder together.
Thank you so much, Kadija. This has been so rich, and I really so appreciate you putting in the context of all that we're facing these days. These are really trying times, and I think it's really the backdrop for all we're doing. We do have a lot of questions, but I wanted to just take a moment to ask everybody to please fill out the evaluation. We very much would like your feedback, and we also use it to shape upcoming trainings as well. So thank you. So we've got a lot of questions. One of the questions is the caregiver quality of interactions is a core determinant of shaping the mental health of the child, but somebody thought it seemed too heavy on the shoulders of the caregiver. And the question is, aren't there some other factors when we consider the mental health of a child? What else is impacting on the child's mental health?
Absolutely. I hope that by trying to explain that the increasing impact of providers' relationships on children, that I didn't tilt the balance to suggest that they held sole responsibility. Obviously, the relational impact of parents and other extended family and primary caregivers is actually, unless there are grave impediments in those relationships, is still actually a more prominent predictor of children's mental health. What I mean by that is the singular investment that parents have in their babies seems to be transmitted in strong ways toward what babies experience and internalize. But what we do need to think about is that it's the combined impact of the relationships that have great import on mental health. The other part that I want to note and did not give a large amount of time to in this presentation was to talk about the baby's contributions to the quality of the relationship. Of course, I talked about the way in which they come into the world hardwired, pre-programmed to make relationships. But what I didn't talk about was their individual differences in infants that contribute to the ways in which they experience caregiving, that a child's sensory sensitivities may make them unable to easily communicate their needs, or conversely contribute to them not experiencing the caregiver's, whether provider or parent, the caregiver's responses as adequately able to assuage a worry or upset or meet a need. So we have to think, too, about the contribution, the innate constitutional contributions of the baby. And, of course, that all mental health concerns are not rooted in infancy, although we want to pay attention to those that are.
Very helpful. Thank you. There was one question about how to help families and children deal with the death of a family member due to COVID-19. I wanted to direct people to a webinar that TTAC is hosting on June 10th. It's going to be facilitated by Joy Oslowski, who was one of the key pioneers in really responding to the Hurricane Katrina crisis, Dr. Jerry Costa from Montclair State, and Gil Foley, who's our clinical co-director. So go to our website and you'll be able to access that. I think it'll be a very rich webinar. So somebody wanted to know where to find the article on heartbreaking choices faced by providers.
Yes, I'm sorry I read it so recently that I didn't have a chance to put the reference into the presentation. It is, and I will get this onto the TTAC website as well, but it is in the magazine The Nation, the April 23rd edition. And I will provide that reference post-presentation.
Terrific, thank you. So somebody was talking about how can the consultant get connected to family child care centers and how can we make them aware of the existence of infant, toddler, and early childhood mental health consultation?
Yeah, I appreciate that question, and I don't know what exists in the location of the questioner or of the rest of you, but I know that, excuse me, when we started to be able to provide consultation to family child care in my program, I made very intentional and repeated efforts to go to family child care associations. I don't know if they exist in all locations, but to find family child care associations that would allow me to speak and introduce the possibility of consultation at their organizational meetings. Again, like what I mentioned in the presentation, the ability to introduce consultation to a group, not just to an individual, also seemed to be encouraging of their participation. Additionally, in connection with resource, and the more that mental health consultation, and I know in New York that there is a strong collaboration and connection between resource and referral agencies who often are very intimately intertwined with and know a lot about family child care programs. That's the ability of family resource centers to provide information about consultation, to host introductory events for family child care providers is another way to be able to begin to introduce our services, as well as to rely on other quality enhancement providers, what I refer to as quality enhancement providers, coaches, who may already be connected to family child care and may be a very potent and important referral source for mental health consultation, to put effort into not only getting to know, but to describe and develop a collaborative referral network with other quality enhancement providers.
Very helpful. So one question was, what factors determine a poor to mediocre quality child care?
The factors that we were talking about are the variables that associate to high or low quality. So the idea of having physical safety, as well as the environments where there was a witnessing and observation of any emotional support being given to children, or great emotional support, where there seemed to be interactions with children that contained pleasure and reciprocity. Those were the kind of measures of high or low quality. There are different measures like the CLASS instrument, like the ECHRS, the Early Childhood Environmental Rating Scale, that have questions that get at some of the characteristics that I just mentioned. Not all of those characteristics, or even the high majority, are about teacher-child relationships, but what was seen in low or mediocre quality centers was places where there was not, what was not seen was emotional engagement, any learning occurring, and where safety was compromised or lacking, to very cursorily describe how low quality is defined.
Thank you. So another question is, how can we help caregivers who themselves may be stressed, dealing with their own depression, instability in the home, economic stressors, interpersonal disruption? What can we do for parents?
For parents and providers? Is the question about both parents and providers?
Well, how can the caregivers support the parents who are dealing with other kinds of things in their life? Yeah. Mm-hmm.
How can the caregiver support the parents?
Yes. Mm-hmm.
I think that by virtue of what they do, that child care providers support parents inherently. I think it's also very important, and I appreciate the question in terms of what more can I, which I think this question is alluding to, what more can providers do directly with parents? And I think we have to start with the idea of recognizing that most of the time in the education of child care providers, and even in the choices that child care providers make about getting into the profession, that we don't emphasize the adult relationship. What I mean by that is that we don't suggest that an important part of providing care, especially to infants and toddlers, is supporting parents. So that I think it's actually an opportunity in mental health consultation to start to emphasize the ideas about the ways in which the provider supports parents is as crucial and has as crucial an impact on the child as the direct way in which the provider supports the child. But what we have to do is, I think, also think about the ways in which providers are supported, to think about adult learning and adult relationships. Because often providers are very well versed in how to think about children. But in my experience, providers sometimes have even gotten into the field because they prefer relating to children than to adults. So that what we have to think about is how we encourage, as mental health consultants, the provider's comfort with adult relationships, at the same time that we don't expect them to provide what we as mental health consultants might for a parent who has the kinds of concerns that were enumerated in the question of serious depression. But to know that their day-to-day contact with the parent, that asking about the parent's experience, not just conveying the child, that matters. Providers can be encouraged and supported to do just that.
Thank you. So someone asked the question, how can you tell if your child is connected? What verbal or nonverbal cues should you be looking for?
I think, again, we mostly feel it affectively, but what we want to look for is what we would refer to as attunement in the moment-to-moment interactions. What I mean by that is, does the child, and of course different depending on the age of the child, but does the child look to the adult for how they should or can feel about a situation? When they are expressing an emotion or interest, do they engage the adult in that interest? When they need help or assistance, have they developed a sense that adults are people you turn to for help or assistance? So the ways in which, through every sensory modality, through gaze, through babbling, through reaching out of arms, do children let us know through their behavior what their expectations, their attitudes, and their feelings are about relationships. They're expressed in how children behave when they are with a familiar adult. They're also expressed in how children relate to strangers. Again, very different depending on developmental stage and age, but children let us know a lot about their expectations by how they approach strangers. Of course, they are always wary and should be, not because a stranger is dangerous, but because they are unfamiliar. But then beyond the moments of strangeness, do they then expect that a caregiver is somebody with whom there is reciprocity? Do they smile at a caregiver with the idea and communicating the idea that they trust that adults are people who they can turn to for assistance or engage in pleasurable activities?
Good response. So we have time for one more question, and the last question is, I've heard from childcare staff that children spend too much time in care and parents need to be home more with their children. How does this preconceived notion attribute to the biases we have?
Yeah, I appreciate this question. It actually, for many decades, the question of separation and the question of time in childcare was the sole kind of argument or debate. And I do think we should be interested in the impact of the amount of time that a child spends in care. But what we know, again, anecdotally, but also backed up from research, is that what matters most is the quality of that quote-unquote substitute care. If you spend long hours as an infant in substitute care that is of abysmal quality, it matters a lot. And research bears this out, that the longer children who are in poor quality child care for many hours a day, their development suffers more than children for whom that is a nominal experience. But I think if the quality of care with a child care provider is, and the relationships are imbued with all of the positive attributes that we've been talking about, then what it does is to simply substantiate the importance of those qualities with the parents. So I don't think that it's a matter of quantity as much as quality. When the two are combined in a negative direction, we have to worry.
Well, Kadija, I just want to thank you, and I want to say this has been such a rich and informative series here, and I'm very sorry to see them end. I do want to remind people that it will be posted on the TTAC website. It'll be probably 3 or 4 business days for the be posted for a written there. Very. And also to say that you will be getting an email about CEUs for those of you who attended all 3 sessions. So, Kadija, this has been a true privilege. We thank you, and we certainly have a lot to digest. I'm in some ways very thrilled to have 3 sessions where we have some time in between to really kind of mull over some of the richness of what you've brought to us. So thank you. And telling everybody, please be safe and well. Do go to our website to see upcoming webinars in the next week. And we hope that you'll all continue to join our learning community. So thank you.
Thank you so much. And please, everyone, take care and take heart. Bye-bye.
Thank you.